The content herein is for informational purposes only, not intended as medical advice, diagnosis, or treatment, and is not to be substituted for direct advice from your doctor.
Today's LymphCast program is proudly sponsored by VitaSupport MD, the makers of Vein Formula 1000 and Lymphatic Formula 1000. These MPFF-based nutraceuticals are backed by science and recommended by doctors specializing in venous and lymphatic disorders. Visit VitaSupportMD.com to learn more.
Welcome to LymphCast, the show that brings together doctors, other health professionals, and special guests to discuss lymphedema, venous disease, and other associated disorders, and what can be done if this is affecting your life. Now it's time to sit back, relax, as it's time to learn all about lymphedema, venous disease, and associated disorders on our show, LymphCast. Welcome to the LymphCast show, episode number 3. Wherein physicians and other medical health professionals, as well as guests, come to our show to tell you all about lymphedema, lipedema, venous disease, and other associated disorders. So let's welcome our panel to today's show. From New Jersey, Dr. John A. Chuback, physician and surgeon. Greetings, Dr. Chuback. How are you today, sir?
I'm doing well, Paul. Always good to see you. Looking forward to a great discussion today and hopefully sharing with our listening audience and our viewing audience some more great information for practitioners and patients alike regarding these important subjects.
Okay, yeah, very good. A lot of good feedback on the very first 2 shows that are already on the podcast page, and people are learning information they didn't even know existed, let alone that it can actually help them. And so we've done some good work already with you, sir. We have a couple of special guests tonight from the Omnitherapy Center in Bloomfield, New Jersey. A couple of physical therapists. Let's welcome them to the show. Ana Pozzoli. Greetings, Ana. How are you today?
Hi, Paul. How are you? Hi, Dr. Chuba.
Nice to see you, Ana.
Yeah, good to have you with us. And Oscar Pozzoli, welcome, sir. How are you today?
Thank you. Very well. Very, very happy to be here.
All right. Glad to have you with us to share your knowledge and wisdom about what's going on with the patients in this world. So let me hand it off to one of you right away. It's whoever wants to take the lead, and the other can chime in after that. What do you do at the Omnitherapy Center that helps patients on their journey through lymphedema, lipedema, venous disease, and everything we've talked about so far?
And I'll take the lead on that. Ana Pozzoli, and I am one of the partners here at Omnitherapy Center in Bloomfield. And my partner is also my husband. And we have been working as a combined therapist in Bloomfield now for 20 years in the lymphatic field, more years of physical therapy. And what we do is we specialize in lymphatic disorders. So treating patients with the diagnosis of lymphedema, whether it's primary, secondary, or venous related lymphedema, that's what we work with. And along the pathway to working with this population of patients, I've also encountered that many patients were presenting a little bit different with lipedema. And lipedema has become one of our other treatment areas that we focus on here at Omnitherapy Center. And what we like to do as a team, we also have another therapist, Dr. Danielle Bloom. She's also certified in lymphedema. And what we do as a group here is we treat from start to finish and trying to incorporate the entire CDT, the complete decongestive therapy, which entails, many different aspects that I'm sure we'll be able to get into. But we're a private practice, and we do very much one-on-one, hands-on treatment from start to finish with each patient. So I know Oscar probably will want to add a little bit more to that, and then we can elaborate on individual things as we go.
Okay, let me turn it over to Oscar Pozzoli. Take it right there, sir. Your thoughts.
Thank you, Paul. Thank you. I think Ana said it very clearly of what we do and the little niche that we have in physical therapy, because let alone there are very few private clinics that literally do the complete decongestive therapy as is done in Europe and so forth. So we focused on that, not just because we love the field, but also because it's a survival way of having a business as well. It's very difficult for a lot of the PT practices to be practicing individualities due to the fact that many of them are groups, very large groups, just such as groups of doctors and so forth. And so our specialty with lymphedema, lipedema, head and neck, lymphedema and so forth has really opened a lot of doors for us. And, word of mouth. We just basically, focused on that. And slowly for the past 20 years, we built up a practice, where I would say 80% is due to lymphedema related sessions. We also do orthopedics. Both Ana and I have Ana has more than 30 years of experience as a physical therapist. I started in 1992, so that's what, 30? I lost count there.
Yeah.
But, and just a little bit about, I'll say a little bit about how I got to this situation. In 1992, when I first started working, I went straight to work at a hospital and immediately started doing wound care. Back then, there was no certified wound specialist. There was basically physical therapists that used to do the wounds. And I focused on that for almost 10 years. And long and behold, working with wounds and, amputations, prosthetics, and so forth, led me to do other things as well. And I studied and I became a certified podorthist, which is the specialist in footwear, the anatomy of footwear and how to prevent, sores and open sores. And then, as Ana has been practicing since she graduated from Europe, she's been practicing lymphatics. We said, listen, there's a lot of situation with patients with lymphedema. So we started focusing on that. And so here we are.
All right. Sounds good. Let me go back to Ana for a second. We want to get Dr. Chuback to weigh in a few moments as well. Ana, in general, and I know it's tough to generalize. In general, it's tough to generalize, but if you could, what do you see more and more? Maybe the majority of cases, do they have anything in particular, or maybe 2 or 3 items that they come to the table with when they come to see you?
There has been a whole changing structure since I've been working in lymphatics for 20 years now. Predominantly, I started working with patients with lymphedema related to cancer. So a lot of breast cancer patients were my first original patient population, also prostate cancer. So lower extremities of males, we would treat also uterine and cervical cancer treatments. Their treatments, it's what render their lymphatic disorders. But being in this field now for 20 years, I started to see huge change, and predominantly related to obesity. Obesity has been one of the driving forces in lymphatic changes. And not just obesity because of the weight, but the impact that it has on the lymphatic system and the vascular system. So it overwhelms the vascular system, then it puts the lymphatic system at work a little bit extra. So, and also in the same time, I started noticing again, patients that came in here and presented a little bit different. And many times the medical community either said, well, yeah, it's a lymphatic situation, but it turns out it's more of the lipedema that I'm seeing. And that's only in females. So, so it has varied quite a bit in the past 20 years that I have been doing this type of work. And you just have to kind of go with the flow and keep up with the studies and what's going on in order to be able to treat appropriately.
Okay, now with your patients, you mentioned obesity. Is it the lymphatic disease disorder that causes the obesity, or is it the obesity that causes issues with the lymphatic system?
A lot of times you could see a combination of the two, but predominantly as obesity expands, as patient gets larger, then if they have an abdomen that is kind of pendulous and sitting right over the lymph nodes in the groin area, that imposes some restriction on the flow and also their immobility. So they get bigger, they're not doing as much, they're not as energetic. Therefore, now they're compromising their entire system altogether.
Okay, last question for you, Oscar, and then we'll go to Dr. John Chuback for his thoughts on what he's heard so far and what he has to add as well from what he's been doing. I'm familiar with physical therapists. A few of them are friends of mine, but they work, with muscles and all that good stuff. What do you do in terms of physical therapy with a patient who comes to you? How do you, I guess that's probably the easiest way to ask the question. What do you do with the patients who come to you in terms of physical therapy?
That's a great question. One of the things I like to look at is the wholeness of the person. Not just I'm coming in here because I have a swollen leg. We look at every detail from the evaluation as to, where's the nutrition? What's going on with nutrition? What's going on with your activities of daily living? What seems to be the most problems that you're occurring with this scenario, this situation? What would be more appropriate for you to reduce that swelling of the leg? Would it take compression socks? Would it take compression garments? Would it be bandaging techniques? And if it is bandage techniques, what type of techniques are we going to utilize? So we look at pretty much wholeheartedly the whole person, not just, the diagnosis. And, we take into consideration family, relatives that can help in with the treatments. So we incorporate the family as well, or a caregiver, to make sure it's followed through. And that's where basically we focus. Our attention to the patient is a whole hour. So we do manual lymphatic drainage on the extremity. We also do the bandaging technique and the patient education and so forth. So we look at it, again, holistically. You have to look at the person, not just, each section.
Okay, out of curiosity, does a patient come to you with a diagnosis already? Like, here's the issue with this person, go see Oscar or Ana? Or do they show up at your door and say, hey, help me, I don't know what's going on? Or is it both? I'm not sure how this works.
Yes, Anna can help me on this one. We have both, actually.
Okay.
We've had many physicians, and some of which have called us and say, hey, I'd like to ask you a question or so, because I've been to a continued education course and they talk about something of lymphedema. And then as I Google it, I notice your name pops up. And so sometimes we get a question, how do you know? How do you relate the difference between a venous stasis or something that's, or obesity or, and sometimes we just simply say, well, is it one extremity? Or is it both extremities? So I say simply sometimes just seeing one extremity being slightly larger than the other would probably indicate that you have lymphedema. Not necessarily as unilateral, you can have it bilateral as well, but simple things like that. And sometimes patients do call. They call because they're learning more, like podcasts like yourself here. They're learning more and they're curious. So we get plenty of phone calls, every day asking, I think my doctor doesn't, they say I have lymphedema, but after I did some diagnosis, I think it's lymphedema what I have.
Mm-hmm.
And so we get a lot of emails, through our website, asking. And so, it's, we get them from, and then of course, physicians, there are vein doctors, there are vascular surgeons who are basically saying, hey, my patient doesn't seem to have difficulty with the vascularity aspect of it, but I think this is more lymphatic related. So why don't you guys go see the husband and wife team in Bloomfield? They may, give you a helping hand. And so we do from there. Sometimes they may just take an evaluation and say, listen, you need my 1 or 2 sessions, and that's good. Yeah.
If I may add a little bit more to that is, in our private practice, we participate with Medicare, traditional Medicare. And with Medicare as an insurance, we have to have a prescription from a medical doctor with a diagnosis and the direction for treatments. A lot of times they would just say the diagnosis, evaluate and treat, and they leave it up to us to make sure that we know what we need to do for the patients. But in New Jersey, we also have, as physical therapists have direct access. So if you have any of the other insurance companies, it's not a Medicare, they can come to us directly. And if we see that the patient is progressing, they're doing fine, we can continue treatment. However, there are situations where if we do our treatments and it's not going the way as we think it should, then it's our job to recommend them to a physician. And a lot of times the idea is for them to work along with the physician so that to make sure that we're all in the same page as to where we're heading.
Okay, a lot of amazing work in this field, and I'm the one non-medical person on the panel today. This is all new information to me, so it's great to hear. So Dr. Chuback, is in the field we're talking about, they would start maybe with a family doctor who says, hey, you better go see Ana and Oscar, and Ana and Oscar try to do what they do, and many times that's enough. But if that's not enough, then that's when they end up in your office. Is that how that whole procedure works?
Well, it goes both ways.
Okay.
It can go back and forth. Ana and Oscar may see patients who they feel would benefit from venous procedures if they think the patient has a form of lymphedema, which we call phlebolymphedema.
Right.
And that can have various causes and treatments. Some of phlebolymphedema is from the superficial system of veins, which we call venous insufficiency, chronic venous insufficiency, which is an inflammatory process which affects the valves, the lining and the valves of the vein, causing blood ultimately to pool in the legs, which can lead to swelling and overwhelming the venous and overwhelming the lymphatic system ultimately. So you get phlebolymphedema, of a venous cause of excess lymphatic fluid and edema in the legs. On the other hand, the patient could have deep system causing phlebolymphedema, where they may have had a deep vein thrombosis in the past, and now they have what we call post-thrombotic syndrome, with scarring of the deep system, which can be obstructive and can also be insufficient. Sometimes old DVTs, deep vein thrombosis, blood clots of the deep system, can cause destruction of the valves. And even if there's no scarring in the deep system, those valves become incompetent in the deep system, and you get pooling of blood in the deep system of veins. So it's a very, very complex system of diagnoses, which we are, all of us assembled here this evening, and the people that we bring to this show have tremendous expertise in. But the general physician out there does not see these problems in the kind of regularity and abundance that we do. So it's very difficult for the general practitioner, family doctor, primary care physician, et cetera, to really make sense of edema. Swollen legs are swollen legs. The old joke, you've seen one, you've seen them all. But this is not a you've seen one, you've seen them all kind of field. Every single patient has typical signs that will tip off a expert clinician that this is a congenital problem. And of course, a proper history and physical goes with that. Speaking to the patient about their own personal history, their own surgical history, their own family history, travel history, infectious history, really good doctoring, good medicine. And Ana and Oscar are both clinicians. They're physical therapists, but they are clinicians and basically functioning in the role of a doctor. I believe that they both trained prior to the days where every physical therapist received a doctoral degree, but in current times, every physical therapist receives a doctoral degree, as they should, because they are doctoring. And a good part of doctoring is taking a proper history, proper physical examination, and that's a very, very in-depth, complex part of taking good care of a patient, which unfortunately in modern medicine is going more and more by the wayside as things are speeding up and computers are taking over and checklists are taking the place of a proper history and physical examination. So all of those things will lead to a proper diagnosis, and typically a good clinician will make the diagnosis based on the history and physical examination in 95% of cases, and will only use diagnostic testing like ultrasound, MRI, CAT scan, et cetera, to confirm their diagnosis, not necessarily to make the diagnosis. And unfortunately, in modern medicine, what we're seeing is the younger clinicians, physicians, and therapists, et cetera, I believe, are relying too heavily on diagnostic testing to get the answer. They say, well, I don't know what's going on here. Send for this test, that test, the other test, and maybe it will bring me some answers. Where people from our generation, we make the diagnosis almost always in talking to the patient and examining the patient, and then you use the diagnostic testing to confirm that. But what I wanted to touch on, Paul, is that Ana was trained in Europe, as Oscar pointed out. And my observation in this field, not just lymphatic medicine, but venous medicine as well, which I've been involved in for almost 20 years now, that the Europeans had a huge head start on the Americans. And I think it's a fascinating subject. And I think we've been playing catch up that whole time. So I'd like Ana to maybe discuss with us, A, her training in Europe, and B, if she agrees with me that the Europeans have been way ahead, and C, why she thinks that is, and how we're doing in catching up with them given the head start that they had.
Today's LymphCast program is proudly sponsored by VitaSupport MD, the makers of Vein Formula 1000 and Lymphatic Formula 1000. These MPFF-based nutraceuticals are backed by science and recommended by doctors specializing in venous and lymphatic disorders. Visit VitaSupportMD.com to learn more.
A lot of questions, but I'm definitely willing to tackle them. So let me give you a little bit of history of myself and my education. I originally started out here in the United States as a physical therapist assistant, and thoroughly loved the job, but doing mostly orthopedics. As working as a PT assistant, I was going to night school, taking my prerequisites to try to get into a physical therapy program. During that time, back in the 90s, it was very competitive in the United States. And so this opportunity to go to Holland, to the Netherlands, to get an education came up. And it was kind of like we were the pioneers of doing this. So 24 Americans were selected from all over, and we were sent to Holland to study physical therapy. We have to have had, of course, all our prerequisites and have some experience in therapy already. Well, while we were all in Holland, we went through our education, which was all year round. It wasn't like semester related like it is here. And it was in English. So it was a little bit tougher for those professors to do because it was the first time that they were doing it. However, we spent a lot of time on the lymphatic system because in Europe, lymphatic disorders was already part of the main curriculum. So our one full semester of lymphatic drainage, it was not just one class or 1 week of it. It was almost an entire semester of it that we had to focus on that, to know the techniques and know the function of the lymphatic system. In addition to the lymphatic system, it was learning about what Dr. Chuback was talking about, is listening to the patient, trying to gather as much information as possible. So one whole section of our evaluation class was on anamnesis, which is gathering information about the patient, and not just what's going on in, let's say, a shoulder. It was a holistic approach, and it was putting together a puzzle. So the more you gather, the more you put together. You had to investigate and then develop differential diagnosis, not a diagnosis. As therapists, we cannot diagnose. We can make a differential diagnosis. So therefore, your skills at observation, questioning, these were our tools. We don't have diagnostics like ultrasound, MRIs, and we're not allowed to do that. At the time, I don't think we're even allowed now, although, most programs are DPTs, which is a doctorate in physical therapy. We're still somewhat limited as to what we can do. So, but that was my basic education and starting to understand more about the lymphatics, but also just in general, the human body, and listening to the patient. And, having a good grasp as to what you're starting with, what our common goals as patient and therapist would be, to come together to get to a point where, all right, let's reach some goals that are attainable. So I hope that kind of answered that question. And also the question about, do I feel that we rely a lot more now on testing? Absolutely. Most of my patients, by the time they get to me, they've seen about 5 different specialists, whether it's your primary doctor, a vascular, a dermatologist, cardiologist, endocrinologist. So all these different doctors are going to do what they're equipped to do. And a lot of times they still don't have an answer. And I can't say that, oh, well, doctors just don't know lymphedema. It's an overwhelming amount of education that they have to go through. And a lot of times I have to say that the main focus has been on, okay, what medications do we need to give to patients to get them better? Rather than, okay, let's find out what's going on and approach it in that form. So I think those were your questions. I don't know, was there another one, Dr. Chuback, that I missed?
No, I think you handled it beautifully. I gave you rapid fire, so I apologize for that, but you did a great job with it. But again, one of the problems that we face is that here in the United States, from the medical school point of view and medical doctor point of view, we still do not have a lymphology residency or fellowship. So part of the problem is that there is no specialist who really is focused on this in the medical field to send all of these patients to. And that's why, as Ana just pointed out, you sort of get these patients who go in this round robin. They see a vascular surgeon, most of whom are largely focused on the arterial system. They don't know about the venous system, and they know almost nothing about the lymphatic system. Then they may see a dermatologist because the patient has skin changes, what we call trophic changes, dermatitis and venous eczema and lipodermatosclerosis and cellulitis and so forth. And then typically they get treated with a steroid cream by the dermatologist. The vascular surgeon recognizes swelling. He says there's really nothing to do about it. Maybe elevate your legs at night and put stockings on. So the patient's not satisfied with that. Then the patient is overweight in many cases, or carrying a lot of weight in the lower extremities. They're told, see an endocrinologist. You may have, quote unquote, a slow thyroid, hypothyroidism, et cetera, et cetera. So they go through this litany of physicians, none of whom has a real expertise in the area of these lymphatic disorders and how those lymphatic disorders, again, overlap with venous disorders, can be congenital, can be associated with what we call iatrogenic causes, Paul, meaning that they were post-surgical, as Ana referred to earlier, or post-radiation for, let's say, cancer therapy in the case of the arm, or even in the lower extremity, groin dissections for melanoma, et cetera. There are many, many classic scenarios that when you're practicing in this area, they're obvious to you. But when you're not seeing these patients on a routine basis, Ana and Oscar were not on our privy to our previous program or present on it, but I do believe they listened to it. And Dr. Iker presented a case of a patient who had been, treated by a cardiologist with huge doses of diuretic Lasix.
Right.
And because the cardiologist is accustomed to seeing swollen legs related to congestive heart failure. So we have an expression in medicine, when you know how to use a hammer, the whole world looks like a nail. So he could see that the legs are swollen. That was the patient's complaint, but he didn't do a good job, thorough job, didn't have the background training and knowledge to make the proper diagnosis. And there is no lymphologist per se to send to. So people like Ana and Oscar, people like Dr. Emily Iker, people like myself, people like Dr. Karen Herbst, et cetera. Slowly but surely in a community, the word trickles out that these are the people to send these people to, but it's not, it takes a long time to get the word out, many years of hard work and taking care of a lot of patients in a community, et cetera. But even so, it's a very imperfect system. It's very different than, let's say, if you have a broken leg, you know that you need to go to an orthopedic surgeon. If you have a skin cancer, you need to go to a dermatologist. If you have chest pain, you need to go to a cardiologist. So this is a field that is falling between the cracks clinically in many cases. And that's why I created the program, to bring people like Ana and Oscar Pozzoli into the light and get more recognition, especially in our area, so that people can find them and hopefully access great care.
A quick question, quick follow-up question for Ana, and then I want to go back to Oscar for a moment. Ana, you mentioned physical therapists at your level in this country, the USA, cannot order an MRI or an ultrasound. Can they do it in other countries, Holland, for example, or are they allowed to do that elsewhere?
No, I don't. In Holland, that wasn't even an issue either. But I think the fact that over there, they have direct access to patients right away, a lot of times you don't even give it a chance to become a chronic issue. So because of socialized medicine, while I was a student there and I had to do clinical rotations, if someone got injured at a soccer game or a volleyball game, they were at the therapist by the next day. So we were taking care of the acute phase of the problem, that it never got to be like a tendonitis or an issue that we then had to wait for them to see an orthopedist. By the time they got an appointment, then their pain had become either worse or maybe gone. It's a little bit different when you have access to patients right away. So that's one of the big factors in getting to your patient as soon as possible and getting to the problem before it becomes a chronic issue for the patient.
Okay, very good. Let me ask Oscar, you mentioned a few moments ago, you drain, see if I have the terminology correct, you drain the lymph nodes. Is that how you said that?
Well, when we look at the complete decongestive therapy, as done in Europe, as done, for instance, in the Foldy Clinic and the Vater style of doing complete decongestive therapy, you're looking at a patient for one session, you're looking at a patient being with the therapist for an hour to an hour and a half. That's almost impossible here. Most of my colleagues who are therapists, unfortunately, see at times 3 to 4 patients in 1 hour. And so I hate to say the word, and my wife probably will say, don't say it, but I am going to say it because to a point, this is almost like a prostitution to physical therapy. Because if my professor knew that we were seeing 3 to 4 patients an hour, he'll just flip. The point I'm trying to say that is in Europe, you take the time with the patient, you do a complete manual lymphatic drainage. And so to answer your question, it is a type of massage, it is a very relaxing massage that is done on the extremity to begin to move the flow of lymphatics so it can move on to from the lymphatic to the vascular to the bladder, so then the patient can urinate the extra fluid out of the body.
Okay.
Afterwards, we want to maintain the continuity of the manual lymphatic drainage, so we use special bandages called short stretch bandages, or as in Europe, they may use things like Coban, and things like, and we have everything here that is related to the compression part of the complete decongestive therapy, and that is the bandaging technique. And so when the person leaves our facility, they are bandaged. They leave their bandages on for a minimum of 2 days. We like to see 3 or 4 days with them on. And that in itself, when the patient is ambulating, when they're walking, they're also, with the bandages, they also are getting the manual lymphatic drainage because these bandages are specially made. They're short stretch. So every time your calf muscle works as you're walking, you're massaging the legs, for instance. And so the lymphatic continues to work its way. And that's how we get diminishing of the girth of the legs. They become smaller, and to the point where we can get them to normal size compared to the other leg or so forth. We take measurements, girth measurements, and then we start deciding, what do we do now? Do we put compression socks? Do we put a compression garment? Do we put, there's multiple things that we can do. So again, I know it's kind of like a long answer to your question, but there's a whole process that requires time. It requires the proper technique. If we're going to do what's been taught for 80 years in Germany.
Yeah.
You can't skip it.
Is this
'cause it
something?
works.
Yeah, is this something your patients then need ongoing therapy, or weekly, monthly sessions, or do they at some point get better enough to not come in for a while? Or how does that work?
That's a great question. We have multiple different patients that can walk into our clinic. Sometimes we may have a very severe case where a person is oozing, their legs are wet, they wet, the pants, their clothes, the shoes. We've had patients that would leave a puddle, while standing in there because the lymphatic fluid is just draining right out of the legs. And so that type of patient we may see every single day, all right, for maybe a week, 5 days in a row, maybe a little bit more. And then once that oozing stops, then we can do maybe 3 times a week or twice a week. And so we start breaking it down as the leg gets better. But most of the time, even the worst severe case, we may see a patient for 12 to 15 visit sessions. And then that's all we need to do. Now we do a follow-up, and if there's a need for them to return. We understand that lymphedema is a lifetime condition. And some patients understand it clearly, and some patients think, oh, this is like a Band-Aid. I got this, I don't need it anymore. Next thing you know, we call them return offenders.
You're offenders.
We call them, right? And so everybody laughs. We kind of like put a plate, we take a picture of them. You're back to lymphedema jail here until you get better. But it is a lifetime condition, but it's very, it can be maintained, and we explain everything. And sometimes it takes more than once, but once they get it, sometimes we don't see patients again because they're doing great. They come by to bring some coffee or something. Hey guys.
Well, let me jump in there a second, because I want to congratulate both Oscar and Ana for this work for that exact reason. I have a lot of experience going back all the way back to my general surgical training days, where we had patients suffering from these disorders in the clinics and so forth. Some with wounds, chronic wounds, cellulitis, infection. And it is a very, very challenging area of medicine, because unlike a really gratifying operation like an appendectomy, for example, where a patient is, very sick and in pain and potentially could die, and with a 45-minute operation, you're the big hero, you save their life, they feel terrific, and in a few days they're eating again and home and so forth. That's an easy field of medicine to practice, I can assure you, having been in that position. Of course, once you learn how to take out an appendix safely. But it's a very gratifying kind of job, and patients tend to be extremely grateful and so on and so forth. And it's not to say that patients in this field are not grateful. They are, but it's hard to be optimistic. It's hard to be positive. It's hard to be upbeat as a patient when you have a problem which is chronic and in some cases progressive, can certainly be progressive without ongoing therapy and treatment. And most of us in modern times, and especially in the United States of America, we like things to get fixed, and we like cures, and we like answers and resolutions to problems that are permanent. And this is a field of chronic disease and chronic dysfunction, which the practitioner has to have a certain personality and constitution and character to be a champion of that patient and continue not only to provide good care, but encourage them, be a cheerleader, uplift them, give them a sense of hope, give them a sense of optimism, ensure the patient that they should not quit in the process, that they shouldn't give up. And it's a very complex subject, going way even beyond the diagnoses that we talked about, going beyond the causes that we talked about. There is a very important, that's why I've invited Dr. Deborah Waitley, the psychologist, to be on our LymphCast panel, because there is a very, very pronounced and profound psychological and emotional component to this disease process that I believe is a huge part of good therapy, and a very difficult part. It's the kind of disease that a lot of practitioners and therapists run away from, because you can't fix it easily. You can't be the hero all of a sudden. And you can fall into the situation where, after a lot of good treatment and therapy, et cetera, when patients are, as you say, repeat offenders, or there's recidivism, and they're coming back several months later because they're doing poorly again, it's not uncommon for a patient to kind of point the finger at the practitioner and say, hey, I thought,
Right.
you said this was going to work. You said that you were going to fix me. You said you were going to help me. And it takes a certain personality that obviously Ana and Oscar have, and I hope I have too, to explain to patients that, I never really said that. We explained to you from the beginning that this is and so education is important, communication is important. It's a very, very complicated field. And I congratulate the two of them for doing it so successfully for so long. And I thought maybe each of them could touch on that aspect of the psycho-emotional and psychosocial component of this very, very difficult disease.
Vein Formula 1000 and Lymphatic Formula 1000 from VitaSupport MD are backed by science and sold in doctors' offices. If you're a physician who may be interested in prescribing or selling these excellent nutraceuticals, please call 862-246-7877 to speak to a representative today.
I can start with that. And one thing, I also want to congratulate you, Dr. Chuback, because we have seen a few of your patients in the past few months, and what they tell us about how you have talked to them and how you have educated them. That has been also a big part of them trying to be compliant with what we need to do as therapists, because many times these are the same patients that already before seeing you, they had seen a whole influx of doctors that really didn't have an answer for them. And so once they find that someone understands what their disease process is, what they're going through, and giving them an expectation, it's a little easier for them to understand. So if they come in and for instance, I'll give you an example. A lot of times I'll get some patients that come in here and they come in with a prescription for lymphedema. And these are my female patients that come in, and as soon as I see them, I could tell it's more of a lymphedema. So the confusion already started. They were told that they have lymphedema. So the natural thing nowadays with social media and technology is for patients to go and do the research. What is lymphedema? And they come in fairly scared, looking at some gruesome legs and some later stages that they think they're going to get into. And then when they come in and I explain to them that, okay, yes, it is a lymphatic disorder. However, it's not lymphedema, it's more of lipedema. So then there's a whole transition. And now, is it more confusing for the patient? Absolutely. Because they were told they had lymphedema. And now it's not that I'm diagnosing, but I'm making the differential diagnosis with them that they're presenting with another type of lymphatic disorder and that they have lipedema. Now they have to go and research this. But once I break down what lipedema is and how it presents to them, and what they probably, because they think I have a crystal ball, because as soon as I tell them, oh, you probably had these legs since puberty, or this happened, that happened, like, how did you know? And so they now start to feel the confidence about telling me more about what their situation is, and you gain that trust. So with patients, the main psychological thing is getting them to trust you. And there are times that, yes, things are not going to go the way that we anticipated. And then we have to go to the drawing board and actually say, hey, is there something else going on that we're missing? Red flags start to go up. And this is when we will either discuss it with the doctor who referred, or maybe refer to another doctor, whether it's a vascular or an infectious disease, or possibly an endocrinologist. So So that's how you would approach that. And you're right, it does takes a special style of being, you know, as a therapist, having sympathy and empathy both, because they're going to go through a journey that is going to be very different. It's not that I'm going to provide a pill for you and you're going to get better. You have to work with us in order to make your condition improve. And we know it when patients are not ready. Many times we had mentioned to the patient during the evaluation, this is what's going to take place within the next, 4, 5, 6 weeks of therapy. And you're going to have to be bandaged. And I understand it's August and it's going to be 100 degrees. And how do you feel about it? And if they're telling me, oh no, I have to wear my cute shoes or I have to go to the beach and I can't have this, my answer to them is, you're not ready yet. So you need to come back when you are ready to commit to this treatment. Otherwise, we're both going to fail. And Oscar will tell you, he never fails. He never wants to fail. So I'm a little bit easier on that.
Oh, and we've been doing this for so many years now. And at first, you remember the things that your professors used to tell you, you mustn't. And then finally, after you get to be a certain age, you say, you know what? No, we just have to be honest, right? But you ask about certain emotional feelings and patients. Oh my God, without me getting emotional, oh my God, have we seen so many different patients? We had a gentleman who has Parkinson's and couldn't move, and also had fluid, just basically, as I was saying to you before, running down both legs. And he had Parkinson's, so he had very difficulty moving. Sometimes he will freeze up on me and I would have to push him a little bit to keep going. And I remember with Anna, I used to say, wow, I wonder how we're going to help him with this. And as we were bringing those legs better and better and better, his medicine kicked in. And the man was moving, and the doctor couldn't believe it. She had to reverse the medicines, because at first when he came, he was taking maximum amount of dosage of dopamine. And the next thing you know, within a few weeks, his legs were down. He wasn't oozing. He was walking better, and the doctor had to remove some of that. And we were shocked, right? That was just one of the stories that we had with one patient. Another patient was a Vietnam vet who came in, had all of a sudden swelling, and doctors didn't know why. And we said to ourselves, there's no primary lymphedema here. He doesn't have prostate cancer. He doesn't have any. Seems that something's going on. And Anna and I started thinking, and we said, look at our history. He's a Vietnam vet. Have we asked him, do you ever have a yellow fever? Have you ever had, he never wanted to talk about Vietnam because he was the front lines in Vietnam. He didn't want to talk about his buddies, but he said, yeah, my buddies, all of them got it. How about you? Oh, I never did. You never had any type? No, I never did. And so we thought, and we said to each other, could it be possible? Could it be possible that psoriasis could be the answer to this? And there are ways of checking that. And one of the things is doing a blood test at night, like a lab that's open at 2 o'clock in the morning. Whoever said that? But it was done. And that was the diagnosis. And finally, we were able to see after so many years, this man had nothing all of a sudden. So, it's just amazing. So there's many other stories that we can tell you, but we would have to be here till maybe midnight telling you all the stories that we've heard.
Great story, though.
But and then we have patients, and then my wife can say that, yeah, sometimes I'll say to the patients, we're done. They come in, and then maybe the second visit, third visit, and they're, no, I don't think I can do this. And then finally I'll say, we're done. We're going to finish today. What do you mean? And we need to be compliant. We have the 3 C's that we want patients to leave, right, Anna? The 3
Right.
C's we tell them, right? You need to be compliant, right? You need to wear your compression. And then the last one is, do you capiche? You comprehend.
Comprende.
The 3 C's we say. And so, patients, they understand. At the end, they understand where we're coming from. And most of them, I would say, Anna, most of them, they do wonderful. They do wonderful as best as they can.
And keep in mind that we are with these patients for 1 full hour. So we become their psychologists. We just can't charge for it.
Good point. I'm glad you pointed that out, that they can't just show up at your door and have you do all the work and they go home and live happily
No.
forever. They actually have to participate in this, right?
Yes. Yes.
Yeah, I'm glad you pointed
It's
that out.
very important that they take an active role in their treatment. You can't just be passive, because then you just go to a massage parlor, because that's what that would be. This is, it requires a lot of things for both lymphatic, lipedema, phlebo lymphedema, whether it's wearing compression, and also following more of an anti-inflammatory type diet, and just even watching. That's one of the biggest things that we're seeing now. Like I said before, that obesity it's becoming one of the main reasons why the lymphatic system is becoming so overwhelmed. So incorporating, not that I'm a nutritionist or a dietitian, but I definitely do a lot of research for myself, for Oscar, and for my patients and my family. So whatever I learn and I can pass on, I definitely do. And I know Dr. Chuback had mentioned Karen Herbst, and how involved she is in lymphatics, and she's always giving some kind of webinar in relation to what is anti-inflammatory and how we can help our patients with that. And there's one coming up, which I'm definitely not going to miss. So those are the things that we need to do for our patients. So it's not just, okay, we wrap them up or talk to them and that's it. No, it's interactive for both.
And if I may, for the last thing, that we also travel many places when we go to conferences, and the last one we've been to was in Copenhagen in Denmark, and we listen to some of our colleagues that work in Europe, they work in Australia, they work in different places, and so we share, hey, what you do. And the number one thing that we walked away from many of our colleagues worldwide, and that is nutrition. And and I think and we see it here, after 20 years, we're beginning to see how bad it is. And it's not necessarily just obesity. It's just the poor nutrition in general, the prepackaged goods, the not taking the time and making fresh foods and vegetables and so forth. And we see it, food is medicine, and including with lymphedema, food is medicine.
Well, of course, you're touching on something that's near and dear to my heart now. As you know, one of our panelists, Dr. Monika Gloviczki, did 15 years of research on MPFF, micronized purified flavonoid fraction, which has had a major impact on my life as we created VitaSupport MD, and we create these products that include MPFF, which is bioflavonoid found in citrus rind, and has intense anti-inflammatory and antioxidant effect. And so that is one component of this nutritional approach to not just venous lymphatic and lipedemic disorders, et cetera, but inflammation in the human body in general, which we know is at the core of so many disease processes now. And it's finally, again, I feel that we were way behind the Europeans here in waking up to seeing what a huge role nutrition plays, and this holistic approach to healthcare, where you have a physician, you have a physical therapist, you have a psychologist, you have a nutritionist, you have a dietitian, you have a surgeon, and so on and so forth. The idea of going back 100 years in this country, where there was one little old man with white hair and a black bag who rode through the countryside and took care of everything, delivered babies and treated fever and set broken bones, that's of historical relevance only now. And we have to open our eyes and our minds to every component of the human body, the human experience, including the psyche, including nutrition, including emotions, including meditation, including relaxation, hands-on therapy, dietary supplementation, on and on and on and on. It's not as simple as we thought it was going to be. Oh, you have diabetes? Oh, take this little pill. You have a high blood pressure? Take this tablet. You have whatever it is, high cholesterol? Take this capsule. It's much more complicated than that. And in many ways, I think much more beautiful than that, when we begin to understand the whole organism for all of its complexities and what it is. But touching on what Ana and Oscar were talking about, one of my favorite philosophies toward nutrition, I heard in a lecture back at the University of Rochester when I was training in cardiac surgery, and I thought that this visiting professor put it so well. He said, the vast majority of Americans are now overfed and undernourished. You see, unfortunately, you look at obese patients, Paul, and you would assume they're overnourished. They're not overnourished, they're overfed. Many of those patients who are obese, if you do blood work on them and you check vitamin levels and trace minerals and so on and so forth, you'll find that they're barely getting any nutrition at all. What they're getting generally is a calorie-dense, sugar-dense, in some cases fat-dense diet, but without a lot of vitamins, minerals, nutrients, etc., and without a lot of nutrition that comes from real foods, whole foods, raw vegetables, raw fruits, etc., etc. So again, to some of our listeners and viewers, some of these avenues we go down may seem or feel off topic at times, but I can assure you it's not off topic. It's dead center of what we're talking about. It really is.
You know, I'll probably say this like 10,000 more times, Dr. Chuback, before we're done with this whole series, maybe 20,000, but this is what you folks do every day, and you do a very good job at it, and you help patients, you treat patients and all that good stuff. I can tell you from my standpoint, never having been in the medical profession, I didn't know about this. I hadn't even heard the word lymphedema until Dr. Chuback mentioned it a couple of years ago, working on another show. And I have a couple of people in my life. One is a cousin and one is a good friend. Turns out they've been suffering from from this for years. They just didn't know it. And kind of like you said, one of you said before, they've been to a series of doctors, you know, take this pill, quit eating so much, and it didn't get better. In fact, it got worse. It almost seems to me, because I don't do this every day, it is maybe nothing short of miraculous in terms of how you're able to help so many people overcome what they're going through. And you probably don't see it that way because it's what you do every day, but I can tell you as an outsider looking in, this is like almost a second coming of medicine in so many ways. Dr. Chuback, your thoughts before we get Oscar and Ana?
Well, thank you for those comments. We've all worked really hard at developing expertise in this area, and no one can be an expert at everything. But I do think that there are an enormous, and I would say in the millions in the United States of patients who are either misdiagnosed, undiagnosed, or both. And that leads to mistreatment, non-treatment, or both. And we're in a tricky situation because, as I said, it's a field of medicine which in many ways has been sort of pushed aside. It's not appealing to a lot of clinicians and therapists for a number of reasons that we won't get into today, but I'm sure we'll cover in our show. Some of which are financial, some of which are, again, regarding patient satisfaction, some of which are regarding time required to spend with each patient, some are regarding patient compliance, as the Pozzolis have mentioned. So it's a very, very difficult field, but at the core, we still don't have a lymphology specialty in the United States. And I think that when a lymphology specialty as either a residency or fellowship comes to pass, more and more of these patients will be funneled to the right centers. And I think that those centers will be holistic centers with a physician, physical therapist, diagnostic imaging center, nutritionist, psychologist, et cetera. That's probably the paradigm for the best case scenario in the future. And who knows, maybe our program and our discussions will help to blaze that path. But there are a lot of people in the position that your friends and family have been in, Paul, misdiagnosed, undiagnosed. And it's a shame because with proper diagnosis and treatment, a lot of improvement can be made in many, many patients, most if not all.
Yeah, definitely. Oscar, turning to you for your final thoughts, and just to make it clear to our audience, you talked about repeat offenders earlier. You don't put their pictures up at the post office, right? We should clear that up right now.
Wait, let me take the camera. No, not at all.
I'm
We
just
have a
kidding.
really good laugh because one of the best medicine is laughter as well, right?
Yeah, yeah.
And so it's like, we do what we do, and we tell patients, listen, you may not believe us, you may not believe it now, but just stick to it, and you'll see that you're going to see improvement. And thank God that once we do the first session, the first complete decongestive therapy, people are amazed. All of a sudden now, the second day, they were able to put their shoes on. Just putting shoes on. It's for them. It's so, they say, I have a closet full of shoes that I wasn't able to put on, and now I can put my shoes on. And just imagine just that moment, just those little moments. And that's what we see every day, thank God.
Yeah, and they can
people
see
say,
it.
how can you guys work with each other? They come in, they say, how can you guys work with each other? How you go home, you go and you work together. And I'm like, thank you. I have my little room. She's got her little room. I see one patient an hour. She sees one patient an hour. We probably see each other at lunch. We don't even have lunch. So we probably see each other in the hallway. but yeah, those repeated offenders, not that many. But
Yeah, I was just teasing. Glad to hear that. And Ana, your final thoughts on all that's been discussed, or anything you want to add?
No, my final thought is it's so gratifying doing what I love to do, and I'm so happy that I found this. Oscar calls it a niche, and I call it my calling to help people. I knew it the minute I came back from Holland, and I started working for the lady who owned Omnitherapy. And the only thing she did for lymphatics was just put them on a pump. She had no idea about how to treat it. She just put them on a pump. She would tell patients, come in and bring a book because you're going to read for an hour. But when I started working with her at Omnitherapy, I said, look, there are ways to treat this. Can we do this? And long story short, she decided to retire and offer Omnitherapy to Oscar and I. And the first thing I did was get rid of the pump and get certified in lymphedema and start the program. And that has been the best thing that came into our lives because, we're both very successful with it. It's gratifying. We get to work together, although we don't see each other, but we work together. And at the end of the day, we go home and we're like, wow, this patient, it did so great. This one's ready for discharge. So a lot of positive things. Yeah, every once in a while, yes, we have one or two that we say, I don't know how we're going to do this one, but let's keep trying. So, and now that we have a new therapist working with us, we have one more set of ideas to kind of kick off as to what we need to do. So, which is great. And so sometimes the two of us, we're females, we gain up on Oscar and we tell Oscar, you have to have that come to Jesus talk with this patient because they're not following, because he's good at that. We're more sympathetic and we let him do the dirty work. So, but it has been a wonderful 20 years of doing this. And like what Dr. Chuback said about getting this information out to our colleagues and also the medical world and patients. Patients push their doctors. Doctors need to push themselves. Colleagues in physical therapy need to realize that this is very gratifying. It's not always about seeing volumes and making a ton of money, but that's not going to make you happy at the end. So those are my closing thoughts.
Speaking of which, Ana, for our listeners, for any physicians who may be in the tri-state area, patients who may be in the tri-state area, please share with them how they could contact you or get in touch with you or learn more about Omnitherapy.
So sure, yes. Omnitherapy is located in Bloomfield, New Jersey. It is 1018 Broad Street, Bloomfield, New Jersey. We also have our email that they can reach us. It's omnitherapycenter@comcast.net. We also, we can't keep up with a whole lot of stuff, but we are on Facebook as well, and also on LinkedIn. So under Omnitherapy, Ana Pozzoli, and also Oscar Pozzoli. So that's one way of either health professionals or patients that can reach us.
Yeah, and also we have the website, which is omnitherapycenter.com, where it kind of explains everything, what we do, and all three of us is there, and they can read, especially a lot of the testimonials.
Great. Well, I'm sure that we'll have you back on the program again. We have an incredible lineup of guests slated for months in advance, but we'd love to have you again. And one of the things that I think would be so great would be maybe even a Zoom related example of some hands-on therapy. If you had a patient who was willing to participate, for our viewers to see what that looks like and what that entails. Of course, not an hour, but
Right.
you know, a brief overview of different techniques and what a patient might expect, and even with wrapping and so on and so forth. So if you'd be open to that, we'd love to have you back and to discuss so many other subjects in the future.
Sure.
Sure.
Okay.
We'll be glad to do that. Thank you for this opportunity.
It's a
Thank
pleasure.
you. Thank you so much.
And thank you, Paul.
You bet. And you've been watching LymphCast number 3, the show that brings together physicians, other health professionals, and other special guests to talk about everything you just heard, lymphedema, lipedema, venous disease. And we want to thank our panel today from the Omnitherapy Center in Bloomfield, New Jersey, Ana Pozzoli, a physical therapist. Thank you, Ana, for being here today.
Thank you.
And also her husband, also a physical therapist at the Omni Therapy Center, Oscar Pozzoli. Thank you very much, sir. Great job today.
Thank you so much, guys. We really appreciate it.
Thank you. And Dr. John A. Chuback, physician surgeon from New Jersey. As always, thank you for putting the show together, and thank you for everything today. We'll see you next time for episode 4.
Thanks a million, Paul. Look forward to seeing you soon.